Okay, so I'm Kim Solez.
I'm Ishita Moghe.
And we're going to tell you about kidney medicine in the digital age. Probably had a sense that digital pathology exists in a larger context than the future of medicine. And we're going to tell you that with a kidney focus, but if your special interest is some other organ, the same things apply, the same context, the same field change where everything will be different from what you thought it was going to be in the future. That would be true of any other area, not just kidney.
Okay, so we'll start by giving you a background and a kind of overview of our presentation. So in kidney medicine and in nephrology in particular, there's been kind of a decline in interest over the past few decades. So here you can see nephrology highlighted. So while the number of trainees and fellows is increasing, it's not increasing at the same rate that it can compensate for the number of patients that actually need kidney care each year. And there are several reasons for this, but one of the main ones is that the methods of kidney analysis and lab methods in kidney medicine have remained stagnant for the past few decades. So just yesterday, Dr. Solez and I were talking, and he said since he's been in the field for over 40 years, not much has changed in the way of kidney biopsy analysis. It's also very chronic kidney disease and dialysis based, which creates a kind of not very unmotivating field since patients are chronically coming back for dialysis until they get a transplant. And we'll talk more about the consensus-based classification coming up, but it's by being consensus-based rather than biology-based, it kind of limits the novel discovery and modernization of the field. So on the potential solution side, on the right side of the screen, we have single-cell RNA sequencing, which was one of the main topics of our talk today. As you're probably all aware, there's single-cell sequencing is really increasing in the output and decreasing in the cost, which is making it much more accessible and affordable for people to use. In the next slide, we'll also give you a few examples of the increasing number of classified cell types. Sorry, I'll just go back to and so the increasing number of cell types, some labs have already started applying single-cell sequencing, and it's been yielding an increasing number of classified sub-cell types since it can detect very low-level gene expression, which was previously just bulldozed by bulk sequencing methods. So all of this is creating much more data that's available for AI.
So if you think about any story that you would tell about any organ, its normal function or function in states of disease, the players are the cells. And since about 2001, 2002, there's been a stable number of cell types in every organ. In the kidney, it's been 26. There was an article in 2001 listing what those 26 cell types are. That's what most people know. Now with single cell typing, we realize that the number is double, and not just in the kidney, but basically in every organ. So any story you tell has double the number of players that it used to have.
So to tie this in with the machine learning section of our talk, whole slide imaging, it's a pretty key player in the digitization of lab medicine and pathology. And studies have shown that human pathologists and machine learning systems make different mistakes, and also that computer programs are able to examine subvisual features that are harder to notice for human pathologists. So, at least in the foreseeable future, computer-assisted diagnosis seems to be the more efficient and accurate way to actually look at slides, since either of them doing it separately, either human pathologists or machine learning systems, aren't as efficient doing it separately. So in terms of solid organ transplant prognostication, in specifically talking about kidney transplants, it's difficult at this point to predict the outcome of kidney transplantation since there are just such a wide variety of diverse factors in the donor and recipient history that contribute to the outcome. So there have been recently published studies using this massive multi-factor analysis using machine learning to try to determine the prognosis for kidney transplantation. And for example, one of these studies showed that the 3-month serum creatinine level was a very significant factor indicating long-term graft success.
So the world of medical research in the future is quite different from what you've experienced in the past. For instance, citizen scientists getting the whole world out there to do calculations for you. That's gamification, crowdsourcing, and you may wonder what the world that we're heading toward, where machines are smarter than we are, first individually and then smarter than the whole human race, what is that going to be like? But if you look inside of any pharma company now, you have that situation now. They're already using quality by design. They are not planning individual experiments. They have computers planning, arrays of 1,000, 5,000 microfluidic experiments all done at once, and the computer then sets the design, the statistics early on. The robots actually do these microfluidics, and there's machine learning analysis at the end. Basically, it's all doing things that humans by themselves cannot do, and that's in every major pharma company now. And what comes out at the end is not just the result of one particular study, but a product. So what comes out is a recipe, the best recipe for the product that they're trying to make, or the protocol that will allow them to do that. And so when you step back and think, well, I was always afraid of an era when machines were smarter than we are, what is going to happen to human beings? You can understand that there's things that will benefit us a great deal that right now humans can't do and machines can, and that will be more and more the case. So I have run for 28 years a consensus-based classification system for transplant pathology in all solid organs worldwide. It's the only game in town in the whole world. And I said, wow, that's really great. But it's consensus-based, right? And so what we should be aiming for, and we are, is something that is biology-based. And it will be based on having the kind of detailed metrics on tissues, on cells, on the story that we tell will be backed up by computational biology in a way it never was before.
So this is kind of a why should you care slide, but I'm going to assume that this crowd at this conference already cares more than the general population. But we just wanted to drive home that the digitization in healthcare, this evolution, is not going to just involve physicians and patients. It's going to involve people in all aspects, in all fields and sectors. And even if you're not directly contributing to healthcare, it's going to affect each one of us as patients. And also we wanted to really drive home the fact that we're talking about every organ system. We're specifically talking about kidneys right now because that's what we're specialists in, but the doubling of cell types, of classified cell types, is something that we expect to see in every major organ system. And finally, for our conclusion, I just wanted to talk about some of the challenges that we might face in this digitization. So all of this renaissance is happening right now because of the availability of huge amounts of patient data through single-cell sequencing and through electronic patient records, and digital pathology and whole slide imaging. This is all contributing large amounts of data. And I think one of the big challenges coming up is infrastructure, in that I think I heard in one of the talks yesterday that only 25 of labs worldwide are fully digitized. And we just have to invest the resources and the time to get this kind of technology into labs and retrain our personnel to actually get the ball rolling on this. And hopefully putting all that huge amount of data through this AI structure is going to yield actionable, integrated information on gene expression, risk factors, precision phenotypes, and hopefully in the future going into diagnostics and targeted treatment.
Thank you very much.
Thank you.
Questions?
So I would point out that if you have any ageism bias, you can bring both ends of that bias to bear.
So this is a
You have
contest.
somebody younger and older than most of you here.
This is a contest you have to decide on the basis of computational logic. Who's older, Kim or me? I have a question. Basically, is one of the inputs into the AI structure, should there also be previous data on outcomes? Because ultimately you want to predict the outcome in a specific instance.
Yeah, I think that to do it absent clinical data doesn't make sense. To have the clinical data overwhelm everything else also doesn't make sense. You know, in the beginning of the Banff classification, I told stories about walking with a surgeon to the microscope. They were saying, it's got to be, right? So that's an impaired intellectual assessment. So you want to hold your ground against the people who say what it's got to be clinically, while still being aware of what's going on clinically.
Well, you know the old expression, you can lead a surgeon to a microscope, but you can't get them to look at it. Are there any other questions?
Any other questions? Yes.
So this was a really interesting talk. So in kidney disease, so you have the electron microscopy level of data, and then you also have, the single cell sequencing data. So do you think you can generate a connection between the two?
Certainly. No, I think that the idea is that in the future we'll be thinking much more about numbers. And you look at a cell and you immediately think of the numbers that were associated with the previous cell. Not just one number, but like, lineage, state, activation, subtype of cell, and where it was oriented in 3D and 4D space and so on. Yeah, everything's related to everything else.
Just to add to that, I think it's really important to integrate both of those, because one of the bigger challenges in single cell sequencing and the molecular data is that there's no spatial resolution. Whereas with our current things like immunofluorescence and electron microscopy, there's high spatial resolution, but no information about gene expression. So I think connecting those two will actually help a lot, yeah.
So you can do single cell analysis while keeping the cells in place. It's a little bit harder, but you don't have to sort of grind up everything so the cells are completely random first. Yeah. Okay, thank you very much.
Thank you.
Thank you.
And the